It's again my pleasure and a great honor to invite a very good friend of mine, Dr. Anuradha. She's a very, first of all, I would say a very nice human being. She's founder, director, and chief scientist officer, chief genetic consultant at GeneTech, Genesis and Genomics Lab. She has done her PhD in human genetics. With her 27 years of experience, she is coming for this lecture, designed multiple novel economic and application-oriented diagnostic tests. We are using many of her tests. Young Scientist Awarded Environmental Mutation Society USA. Postdoctoral work was done in USA. She has multiple paper publications, 350 plus CME lectures, and designed world's first and most comprehensive NGS-based genomic panels for infertility and recurrent pregnancy loss. With great pleasure, I invite Dr. Anuradha. Please enlighten us. We have Dr. Anuradha with us. Dr. Anuradha?
Hi, Dr. Nisha. Can you hear me?
Yes, we can hear you.
Yeah, thank you so much for the introduction. I'm unable to share I think once you stop the share, I'll be able to share my...
Yes, Mohit, can we please stop the share? Yeah.
Leaders, females. Are you able to see my slide?
Yes, we can see Dr. Anuradha.
Okay, all right. So let me...
Ma'am, just click on that trophy icon on minus sign, ma'am, in the zoom in. On the negative sign, ma'am. On the negative sign, there is a trophy, ma'am. Icon of the trophy.
Okay, just
for the slideshow of that presentation.
Okay, let me just... where is the trophy?
Actually, on the zoom in, zoom out.
Let me just share again. Just give me 1 second, please. Okay. Let me see if I can share now. Share. Yeah. Are you able to see now?
Yes, ma'am. Yes, ma'am. Please go ahead.
Yeah. Okay. Are you able to see the whole slide? I'm unable to. Some problem here. Just hold on for a minute, ma'am.
Ma'am, on the negative sign, on the left side of 100%, there is a cup or the trophy sign. Just click on that.
Yeah, I'm unable to see that. Just hold on for a second. Please hold on. I'm just call somebody to help me. Sorry about this.
Dr. Anuradha, at the bottom, can you see 100% written? At
no,
the bottom,
actually,
you cannot?
I cannot see that. So I'm just trying to... 1 second. Let me just give me 2 minutes.
Ma'am, is it possible that we could show ma'am slides? Mohit could do that if ma'am sends her presentation.
Yeah, I can ask her. Dr. Anuradha, can you share your PPT with us? We can share from our site. Dr. Anuradha?
Okay, can you see the slideshow now?
We can see, but it is still in that same format. Can you please share the PPT with us? I will share, Mohit will share it.
Okay, Dr.
Yes,
Nisha,
ma'am.
can you see now?
Yes,
Yes,
yes.
ma'am. Yes, ma'am.
Yes, it is perfect.
Okay, thank you so much. Sorry about the inconvenience. So I'll quickly start the lecture. So what we are seeing here is, so today we'll be discussing about the role of genomic variants and polymorphisms in infertility and recurrent pregnancy loss cases. So what I will be talking about is how to manage infertility using individualized treatment. And now this specifically, I have done this for Indian population. So if you have any questions about how it has been designed and all that, I can answer at the end of the lecture. So now this is the second slide, which just shows that irrespective of all the technologies that are available to us today, our success rate of IVF treatment is somewhere around 40 to 50%. And we have a lot of testing opportunities that we use, including hormonal, genetic, ultrasound, and other immunology and infection panels, etc. And also for male diagnosis. At the end of the day, we still have around 42% published rate for IVF success. Now, what are the limitations of the current investigations that we have? If you see here, clinical parameters are excellent. We need them, but they always offer a broad guideline for the root cause of infertility to be diagnosed. Karyotyping, yes, it is mandatory for all infertility patients to understand if there is any balanced translocation. But how many of times do we see this balanced translocation? In less than 10% of cases, I would say in less than 5% of cases. So the karyotyping doesn't give always an accurate root cause. And then we also apply PGT-A, which is aneuploidy. And of course, I'm not going to talk about PGT-M here because that is only specified for cases with a risk for monogenic disorders. But if you use PGT-A, the chances that you will have less recurrent pregnancy losses and more implantation is already proven. However, transferring a euploid embryo does not always guarantee a successful live birth. Of course, we have endometrial receptive assay, which the major limitation is to do it multiple times. And carrier screening, as we know, is done for IVF patients, couple. But the thing is, it is only useful in majority of cases, a risk for offspring, but not infertility root cause. So with that, let us enter into the advent of genomics-based ART. This slide, I don't want to spend a lot of time on it, but then we do know that every cell has chromosomes. It's all been covered, and the chromosome have the DNA code on it, on the double helical DNA, and then the code actually produces proteins which do different functions in our body, starting from gametogenesis to pregnancy and then the live birth. Now, if we look at the genomics data, looking at all the publications, large percentage of infertility cases are because of constitutional genetics. Now, what I mean by constitutional genetics is maternal and paternal genomes are responsible for the infertility cause. Now, there are two types of changes that can happen on the genome. One is a mutation, the other one is a polymorphism. Mutation is the one which changes the protein or does not produce the protein at all, and then the effect is usually same in all human beings. But then there are polymorphisms also, which are changes in the genetic code. If you see here, A becomes a G. The protein may not be completely eliminated, but then these polymorphisms put an individual at a higher risk of developing a condition, including infertility. So polymorphisms should be looked at a different level and mutations at a different level. And both these have a role to play in infertility. And what we have here is the work that we have done, and I just want to present our IP here, where we have actually worked on around 10,000 cases, and these are all based Indian population, South Indian and North Indian population. And we have looked at the jivas and different population studies. We are also currently working on Malaysian and Singapore population, but the Indian population data is available with us, which tells us, looking at the 360-degree coverage of fertility correlations. It includes mutations, it includes risk-causing or risk-enhancing polymorphisms that are associated with infertility. And because infertility is not a single gene disorder, multiple genes are involved, and therefore polygenic risk score and odds ratios must be calculated so that the risk for an infertility condition can be provided. So the basic idea is to look at the mutations and polymorphisms in maternal and paternal genome and determine the risk for infertility. We do paternal with gene andro and maternal with gene femina. These are just the names of the tests. Now, what are the things that are today correlating with infertility and genetic correlations are, there are several genes associated with gametogenesis, oogenesis and spermatogenesis, premature ovarian failure, fertilization failure, poor fertilization rates in ART, embryonic developmental defects, oocyte maturation defects, recurrent implantation failure, pregnancy loss, and other pregnancy complications. The idea is to look at the genome and not only identify the root cause and the risk associated with it, but also provide drug implications. So the ART area is showing a lot of publications where drug implications are being reported. So it is very important to understand that such implications can now be provided, and ART protocols can be modified accordingly so that we can achieve highest success possible. And donor and surrogacy recommendations can be easily done with evidence and scientific basis, rather than just recommending donor or surrogacy because of previous IVF failures. These are different publications. Again, I don't have time. I understand I myself wasted a few minutes to actually talk about all these. But anybody interested, you please contact Dr. Nisha, and I can send all these publications to you, where current literature is now talking about pharmacogenomic implications in IVF and how do we design precise personalized medicine and treatment and management for IVF patients. So there are some international publications that I just put up. Now we can move to female infertility. There are around 250 conditions of female infertility that we address. And what are the indications for all the conditions that we look at when we look at the genome of a female? Ovarian and uterine condition, like a POI or diminished ovarian reserve, polycystic ovarian syndrome, endometriosis, pregnancy losses, recurrent implantation failures. How do a woman respond to controlled ovarian stimulation? Is it poor, good, or high? What is the oocyte retrieval rate? What's the quality of the oocyte? What about oocyte maturation defects, ART fertilization rate, etc.? And then followed by drug implication and how the ART protocols can be modified, including AOI and in vitro maturation, embryo cryopreservation requirement, etc. So let's move on to controlled ovarian stimulation first. Then I just wanted to tell you that every infertility specialist's dream would be to get 15 oocytes, but then we don't see that in a practical setting in a clinic. We see poor oocytes, less than 5, suboptimal 5 to 9, good 10 to 15, and hyper more than 15. Clinical parameters like AMH, AFC, and estradiol, they don't always offer accurate direction as to what will be the outcome of the controlled ovarian stimulation. So the way forward we propose is the genomic evidence, and it is based on multiple literature available out there. Around 30 genes are associated with poor response as of today in all the studies, and 6 genes are associated with ovarian hyperstimulation syndrome. And it again, as I said, because it's a multigenic condition, the odds ratio must be calculated, and then based on that, a specific drug selection must be done for controlled ovarian stimulation. Again, there are several protocols that are publications that have been published already. Alvigi in 2023 talks about how genetic variants influence controlled ovarian stimulation. Mind you, these are all population specific, so we need to work on a lot of data to understand what is more important for Indian population. And here I just wanted to show you 3 cases where I will be, in one case, we are looking at all of them with primary infertility with IVF failures. In first case, we are seeing that there is an FSHR gene variant, which many of you are aware of. And we see that this is a poor response and needs higher gonadotropin dose. In second case, we found a LHCGR gene variant. Again, this gene variant is associated with slow and suboptimal response to controlled ovarian stimulation, and adding exogenous LH, recombinant LH in the first cycle is highly favorable for these individuals. And then again, we also, I will just put up a case of KIS1 gene. This gene is highly associated with the ovarian hyperstimulation syndrome and high response, and preventive strategies must be employed with that woman if she has an OHSS risk. So here, I will now show you some Indian population specific related publications that we showed. Around 500 samples were used in this publication where from Hegde Hospital, Hegde Fertility Center. And we have demonstrated improved response of controlled ovarian stimulation. These are the genes that are associated with controlled ovarian stimulation response: AMH, AHR2, ESR1, ESR2, FSHR, and LHCGR. And when there is more than 2 genotypes associated, there is 3x risk of poor response, and 5x when 3 genes are involved. And FSHR alone, which is popularly known for its prediction, is not in more than 15% of cases associated with controlled ovarian stimulation. And based on this, we have actually pushed a big group of suboptimal response to good response based on the genomic information. Again, all these papers can be shared whenever there is a request. Here, this is a very big data that is under publication, but I just wanted to inform you that it's the largest data available in the Indian population, first ever. And LHCGR variant has been reported in 2 years. We have followed up these patients up till live birth, and we found that exogenous LH stimulation gave favorable results. And the success rate that we have measured has drastically improved when we have supplied recombinant LH stimulation to individuals with LHCGR variation. This is another case publication that we, case publication of 12 cases with Apollo Fertility Center, where we have demonstrated that there are genes associated with hyporesponders, not the poor responders, but hyporesponders. And when these hyporesponders were given treatment according to the genotype that has been associated, we have seen success rate in 10 cases. And this is a good improvement. Then looking at premature ovarian insufficiency, there are several gene variants and mutations that are associated with POI, not just the Fragile X. Fragile X FMR1 related gene is associated with the POF type 1, but there are 21 types of premature ovarian failure or insufficiency, and several genes are involved in the etiology. And once you identify these POI cases, although not all of them show a full-blown POF case, they could just be presenting with idiopathic or unexplained infertility with poor AFC. You can suggest fertility management based on the evidence. And in many cases, PRP treatment is shown to be very useful for certain genotypes. Again, anybody interested, I can share that data. This is a large publication data that is available on POI, how the landscape of pathogenic mutations and even population-specific variants are affecting premature ovarian insufficiency, and that needs to be addressed based on evidence. Here, I just put up two cases just for your information that in one case we have seen FOL2 gene variant. It is associated with premature ovarian insufficiency. And in another case, we have seen NOBOX gene variation, which is type 5. And in both these cases, we need to do a fertility management through preservation. Oocyte maturation defects, again, are very, very important. There are 20 types of oocyte maturation defects, and it's a complex process of maturation by itself, and multiple genes are involved. And based on what gene is involved, you could take a call on how to manage the oocyte maturation defect related issue. For example, if someone has a ZP1 gene variation, then we are sure that they are going to have degenerated oocytes, and OD cycle would be much preferable rather than wasting time on self oocytes. Of course, this has to be counseled and informed to the patient. If they are willing, you could then suggest a OD cycle. In some cases, ICSI can be favorable. For example, in a gene variation with ZP2, you could think about a ICSI process and not go directly with the OD cycle. TUBB8 is a gene variation. Certain gene variations in TUBB8 gene are heavily seen in Indian population, and they result in early cleavage. And some of them that we have noted in our large data proceeded to early pregnancy, and then there has been a miscarriage. So inevitably, there will be an embryonic development issue. If not, even if they conceive, it is going to result in a early miscarriage. And therefore, in these individuals, it's always better to do a OD cycle. Again, several publications, if someone is interested. In the last 5 years, oocyte maturation defects publications have increased drastically because of large amount of data that we are able to now screen and sequence. And again, there are population-specific genotypes that are associated here. This I will not cover, but because I already talked about TUBB8, it just disrupts your spindle fibers in the embryo, and it does not allow it to grow in the oocyte, or if not in the embryo. And LHCGR also can cause genuine empty follicle syndrome. And if there is LHCGR variation, which is not the one that I have discussed before, a new variation, pathogenic variation, if this variation is present, it will inevitably result in a genuine empty follicle syndrome and LH resistance, and there is no point using the self oocyte in these females. Next, I will move on to recurrent implantation failure and recurrent pregnancy losses. Again, a lot of data available. We do know that there are F5, F2, common prothrombin factor 5 kind of genes, but these genes are not really associated in a large scale in Indian population. Of course, one idea to know for sure is that there are several types of pregnancy loss related genes: thrombophilia, immunology, trophoblast environment related, oxidative stress, folic acid, homocysteine metabolism, etc. But the most common things that we see, that we hear about, like factor 5 and prothrombin, are not associated in Indian population, very, very few. But there are new genes, of course, MTHFR gene, also the most prevalent mutation in Indian population, is different from the one that is reported in Caucasian population. MTR, MTRR, PROZ, VGFA, and PAI1. These are the genes that are highly associated with thrombophilia-related pregnancy loss. This is another publication of ours on a large population study showing Indian population-related pregnancy loss genotypes. This is just a slide to show you how you can manage your cases once we know that there is a genotype that is associated with pregnancy loss. For example, in first case, there are 3 genotypes, MTHFR, MTR, VEGFA. All the 3 are associated with pregnancy loss due to thrombophilia. And there is a 5-fold risk here. And of course, you will help them with therapeutic anticoagulant dose, the highest anticoagulant dose. Giving anticoagulant to every pregnancy is not scientific, and based on evidence, if you know that there is a very high risk of thrombophilia, then you can give therapeutic dose of anticoagulant. And MTHFR and MTR also play a role on DNA synthesis, and therefore you might want to consider PGTA in these individuals if it is an IVF setup, or of course NIPT in an obstetric setup. Because the DNA synthesis irregularities, there is an aneuploidy risk for these individuals. There is immune dysregulation can be caused by multiple genes. In second case, you see that there is IL-10 and IL-21. In these individuals, you will have to think about an anti-inflammatory therapy, some kind of immune support. Again, it depends from clinic to clinic what kind of immune therapies they would like to give. That could be a steroid, it can be a PRP or intralipid treatment, but immune support would be required for these individuals. These are all preventive strategies, and somebody with a MDM2 kind of genotype, especially prevalent in Indian population, you can think of supplementing them with antioxidants. And of course, every one of us know that some people respond very well to antioxidants and some people don't. But MDM2 related genotype, females respond very well with antioxidant therapy. So now I'll just move on to male infertility also. There are several conditions, around 150 conditions that we look at in male infertility, again on Indian population. Male infertility conditions that are associated with mutations and polymorphisms include azoospermia, severe oats, all spermatogenic errors, low testicular volume, low semen, hormone-related issues, sperm DNA fragmentation, high DNA fragmentation, fetal aneuploidy, sperm structure-related issues, cilia, flagella, head, acrosome, and the function of
Dr. Anuradha, a gentle reminder, please.
Sure. Can I wrap up in 6 minutes? Is that fine? 5 minutes. I'll wrap it up. So sperm function, motility, zola pellucida, oocyte activation, all these are also involved, and of course cystic fibrosis related. This slide I will not go into detail. As you all know, AZF gene deletions are associated with male infertility, and our panel includes that. But the catch is here. If we looked at 150 cases of azoospermia and found that only in 3 cases there is AZF gene deletion, and another 147 cases we have other genes reported. So it's important that we need to look at a complete genomic pattern. And one very quick information about some of the FSHR genotypes in male. When you have a male with FSHR genotype and they have spermatogenic anomalies, then please use recombinant FSH as a treatment mode, and they give better outcome. This we have published a case report in Fertility Science and Research, which gives the protocol on how to use recombinant FSH. And another 500 cases have been presented with Dr. Firuza Parekh at ASRM. This also talks about the protocol for recombinant FSH. Some of the sperm are unable to penetrate the zona pellucida if they have a variant in CATSPR1 gene. And in such cases, you will have to go in for an ICSI and not waste time in IUI. Some of the genotypes require assisted oocyte activation because they have a mutation on PLCZ1 gene. And these individuals, you can easily use ICSI AOI and they will be able to conceive instead of wasting any time on IUI or any other methods of. I'll not go into these details as short of time. Androgen insensitivity also can be addressed, and oxidative stress in male can be caused by variations in SOD2. We have found a specific variant in Indian population which is associated with oxidative stress in males. And for these individuals, antioxidant supplement should work. And whenever there is a mutation which tells us that there could be a non-obstructive azoospermia or high DNA double-strand breaks, and there is no way we can actually use the self-sperm, in those conditions, we could suggest a DNA, donor gamete. Example in TEX11 pathogenic mutations. Yeah, it's the blood samples should be collected in EDTA because this is a DNA test, and multiple tests are performed on multiple genotypes for genotype analysis, and that report could be generated. So with that, I really thank you. But the whole idea to introduce this is to tell you that there are multiple mutations and multiple polymorphisms that can affect infertility, pregnancy loss, and implantation failure. And specifically, the polymorphisms are associated with population groups, and we need to identify them and address them accordingly. Thank you so much, Dr. Nisha, for giving this opportunity. And I can take questions if you have any now or at a specified point that you would like.
Dr. Anuradha, we'll keep the questions at the end. Now, we are a little short of time, already 20 minutes late. And Mohit, can we have the next CV, please?